I'm Anthony Leeds, and it's my pleasure to welcome you to this next episode of our series of conversations with colleagues and others with whom I've worked over the years. And today, in response to requests from some viewers, and I was very pleased indeed to get those who asked that they should see and hear from Mr. Sufi, who is the consultant bariatric surgeon at the Whittington Hospital in London. And previously we talked about bariatric surgery, and today we're going to consider that topic again and see what advances and changes there have been, in addition to the general issues about its application. So, Mr. Sufi, thank you very much indeed for joining us. Perhaps we should begin, bearing in mind that some viewers may not have heard what we've discussed previously, explaining exactly what is bariatric surgery and what's the principle underlying the use of this type of intervention, or what are the principles?
Thank you very much, Tony, for the kind introduction. So bariatric surgery, the word bariatric comes from baros. So we're dealing with heavy patients, and it is the science of treating patients who are overweight to help them reduce their weight and the consequent health issues that they inevitably develop at some stage of their life. It goes back many years when we did not have the current options. One of the earliest options, of course, was bulimia, as we know that the Romans used to try and control their weight by vomiting and purging. So you eat and you do that. So that is again an attempt to control your weight. Later on, we had surgery by actually wearing up the jaw, so you could not eat. That was only moderately successful, because obviously people found ways of sipping things from their closed jaws, and that did not quite work. However, people noticed that when we operated on patients for gastric cancers and ulcers, and we gave them partial gastrectomies or gave them some sort of bypass, like the Billroth-2 bypasses specifically, patients lost weight. And that's what started people to think, or people started to think as to why this was the case. The difference between Billroth-1 and Billroth-2, as you know, is that the food bypasses the duodenum in the Billroth-2, whereas it does not in Billroth-1. So that's where the research started, and people started thinking, well, that's a good option. And that was the birth of the RY gastric bypass, the first really effective bariatric surgery, which is still there. In between, there
when was that first done, that type of surgery, for the purposes of achieving weight loss? It's quite a long time ago now, wasn't it? 30, 35 years ago?
In fact, even longer, actually. It was being done, not in large numbers, but in the 1960s. But yes, it started being done in large numbers about 35 years ago, laparoscopic. Before it was open surgery, and then of course it has changed to keyhole. And then afterwards we have developed other operations like sleeve gastrectomy, duodenal switches. Duodenal switch was the second operation, effective operation. And both the mini gastric bypass and sleeve gastrectomies have come out respectively from these operations to make things simpler and easier. These are the major operations. There's another operation that used to be done a lot, but is being done less, but still effective, and we still see quite a lot, which is the gastric band. And that was very popular up until about 10 years ago, when the other options have taken over compared to the band.
Now, with the bands, of course, they do require a lot of work on the part of specialist nurses in the period after they've been inserted, don't they? And not all providers are able to do that. The other thing I think with bands is, am I right in thinking that sometimes these people are more likely to come back several years later and actually ask for a different type of surgery, perhaps because they've not lost enough weight?
Yes, band is particularly good for certain types of people who have got a better handle on their eating habits, and they have the time to eat slowly, and they do need a lot of support. And in a resource-restricted environment, especially in third world countries, it may not be that easy for patients to come back from their environment to the health institute to have the bands adjusted. So it's very much a first world type of operation, and it's still done, and it needs support. If you have got a good setup where the patients can access band adjustment on demand without having to wait 2 or 3 months for an appointment, and can come back for deflation if necessary and investigations. Then band is still a very effective and good operation. Don't forget the gastric balloons, which are not exactly operations, but they're procedures, and they're also done in quite large numbers.
With regard to the numbers of people who are benefiting from this treatment at the moment, I mean, whenever you and I have discussed this in the past, we've lamented the fact that there are vastly greater numbers of people in the UK who actually need this type of treatment. Interestingly, I've looked up some figures, and in France, which has a similar sized population, the most recent figures for the number of bariatric surgical procedures carried out was about 40,000 compared to 4,000 or so on the NHS in the UK, and maybe 5,000 or 6,000 in the private sector in the UK. So there's a big differential, and of course Sweden and also the Czech Republic also do a great deal more bariatric surgery, don't they? And why is it that there are such huge differences between the countries? Is it a question of provision of the sort of supportive services that are needed and the number of high dependency beds and all those sorts of problems that we've discussed before?
Well, the NHS is cash strapped, isn't it? So yeah. NHS has got the dubious distinction of being very effective in treating cancers and for example things that are life-threatening, accidents, emergencies, but it is not so good at delivering other services which again require money, but because it is neither a business so that you can do things and expect the remuneration is the same amount of money, and therefore you want that money to go further, and therefore you end up having to fund your cancers and your hips and knees and perhaps diabetes, which takes up, as you know, a lot of resources, blood pressure, stroke, heart attacks, and therefore obesity is a very poor cousin. So this is something that has to wait in the NHS, and that is the real problem for us.
Yeah, but the interesting issue though is that with regard, for example, to diabetes, my understanding is that you can demonstrate that the cost of actually undertaking surgery is recovered after 3 years in terms of the reduction in other costs which have occurred in terms of medication and so on. And then also, if you look at the very long-term results from the Swedish obesity subjects study, I think it's now 26-year data, the benefits, both in terms to the individual, in terms of health, but also cost reduction, are really very, very clear. So in the longer term, you actually should A, improve the quality of life of the individuals involved, and B, should incur less healthcare costs. Is that correct?
Absolutely. Stitch in time saves 9, but sadly we are not very sort of famous for stitching in time. So we end up having to deal with the consequences, and it's very well demonstrated that actually if you do the treatment earlier on in the metabolic journey, so that you're doing it instead of doing at 10 years when metabolic side effects have already set in, complications have set in. If you do it at 2 years, 1 year, then the results are going to be much better. The incidence of diabetes in remission, the incidence of mortality and the other complications are going to be less. But again, we are a cash-strapped health service, and therefore if there is a debate as to which patient should have the operation, the one who has got diabetes and complications, or the person who has got a bad knee or hip and needs to have a hip or knee surgery, or the person who is actually mobile, has got just developed diabetes 2 years ago, diet and is controlled with diet and medication like metformin, who should be offered bariatric surgery. Sadly, at this moment, the ones who are worse off, as I said, because we are resource limited health system. But if the resource was unlimited, then of course the low risks would be prioritized. Just as I would say what would happen in an event when there is a major event, let's say, and that our resources are overwhelmed, there is a bomb. So which patients do we treat first? The ones who are going to survive and have got a lot less likelihood, or do we actually deal with the ones who are bleeding and the ones who are? So it's a bit like that, really. So looking at a cash-strapped, resource-limited environment.
Yeah, but we also know that within the population there are a number of different groups, aren't there? And we now know that there's a very small proportion of people who are very heavy indeed. And I believe that in Scotland, for example, it's between 2.5% and 3% of the population who would count as being super obese or super obese. And I know that you've seen one or two such people. For those individuals, presumably, surgery really is something that should be quite strongly offered. And I know, having worked with you for a number of years, that we've actually helped some of those people to pass through very successful pathways, haven't we?
Absolutely. Just this week, I think I saw a patient who I operated on like this, and the patient was very grateful because the patient has now had a child, is able to walk without the constant pain that he was experiencing before. But as I said once again, the results are there. They speak for themselves. It is without doubt very useful. But who should get it is a contentious issue. Who should have access?
Yeah. The other interesting thing is that I know that studies have been done in Glasgow over the last 2, 3, 4 years on the actual costs of providing all the needed services for the very, very heavy individuals. And actually the cost to both the healthcare environment and also social services and other providers can be extraordinarily high. And if you could actually catch those individuals early on in their pathway towards being very heavy, and presumably bariatric procedures would play a part in that, there should be major savings. I think that there's a lack of realization that that small percentage of the population really are very needy and very expensive to help.
And the politicians are not elected for 20 years, they're elected for 4 to 5 years. So they're looking at cost saving now rather than cost saving long term. That's the problem. So we haven't got the long term thinking.
Yes. So let's now then thinking of those very, very large individuals, and obviously you and I saw a very large number of quite a number of people passing through both preoperative preparation and then the surgical procedure. How important is it for those individuals to lose some weight before they go for surgery, on the grounds that it perhaps makes the anesthesia easier and it makes the surgical procedure easy? So think of people who might weigh 180, 200 kilograms. How critical is it to try and lose 10, 15, 20 kilograms before surgery? I know we've seen patients who've managed to do that, and well done to them for doing it.
In my opinion, Tony, is very important. It makes a huge difference in the operating time and the in hospital time. The operation can be done even without patients having lost weight, but then of course that means that we end up doing a suboptimal operation. The sleeve is perhaps not as tight as we'd like it to be. The gastric pouch is probably longer than what we'd like it to be. We might suffer from more injuries. The operation that we could have done in 45 minutes, 50 minutes end up being a 5-hour operation. It is well known that the longer the patient is on the table, the higher the incidence of complications like deep vein thrombosis and other things. So I think that it is really useful. It can also be used to see as to which patients are able to comply, because there are some patients who are not able to comply with the dietary changes that will be required long term in order to be successful. And bariatric surgery should not be offered willy-nilly. And just like anything else, I mean, it is a tool, but it is a tool that has to be used along with other tools, which includes a good lifestyle, diet, physical activity. And if someone refuses to engage, then sadly bariatric surgery will fail. And not only that, not only they will fail, they might even develop complications. Again, that was saying complications like I've seen this patient that I was talking about that I've been able to help, and he's now 7 months down the line. He had his bypass. I've seen him twice. HPC him on a monthly basis, and both occasions he has sheepishly acknowledged that he's not taking his multivitamins at all. So this is a gentleman. He's probably going to develop nerve injury. He's going to develop problems he just doesn't realize. I'm not quite sure why we can't get this to him. He has got the supplements. He's got them at home, but he just doesn't take them. What can we do?
Yes, no, that's difficult. Now, also another important thing that's changed over the last few years is the availability of the GLP-1 agonist drugs, which of course were available some time previously for treating diabetes, but then became very widely available on the open market in ways which perhaps many of us are slightly concerned about, but they are there. And my understanding is in the United States they are so available that the numbers of cases going forward for bariatric surgery at this moment in time is somewhat reduced. So there's a reduction of bariatric surgery in the United States, I think I read. What do you think will be the effect of GLP-1 agonists on the sort of perception of bariatric surgery, in that you can achieve very big weight losses, you can achieve dramatic changes in the metabolic conditions, and also evidence of cardiovascular risk improvement and so on. So these are very potent drugs. Now, having said that, we have also to remember that I know there's a team at Imperial College in London who are experts on the gastrointestinal hormones who have been trying to mimic the effects of bariatric surgery using patterns of hormones administered as pharmaceuticals. Do you think that we're getting close to the point where this type of drug and other similar drugs might actually ultimately replace bariatric surgery, or do you think that bariatric surgery is here to stay?
I think that at the moment bariatric surgery is here to stay. The numbers may have reduced in certain settings, but that does not take away from the number that need bariatric surgery. Just like anything new, this is something, the medicines are there. We welcome the arrival of the medication. It has allowed weight loss strategy to be improved so that patients who are not able to access bariatric surgery can benefit. So it is of real importance that we have access to these medicines. Long term, what happens, we do not know. Like any medication, there are, as we know, that there have been many other medicines that have come and gone. Tenuate, Duspa, Rimonabant, Sibutramine, they have come and they were effective as well. So long term, I think that we have to wait for 10, 15 years before we know whether long term these medications will be in our armamentarium. But even if they don't stay, there may be new medications. So we of course welcome. Medications are not cheap. I mean, if you look at the UK cost that I was just looking at the costing in the NHS, the cost for the GLP-1 analogs of over 5 years would equate to having a gastric bypass. So if someone had a gastric bypass and then there is relatively very little input apart from the vitamins and minerals and the blood tests that they will require once a year, where the GLP-1 agonists will have to be maintained indefinitely. And there is a failure in surgery. There's a failure rate in GLP-1 agonists as well. So they are effective, they are useful. So if someone is presenting with BMI 32, no diabetes, but patient has got, let's say, bad hip or bad knee, or BMI 34, and needs a hip replacement, a knee replacement, what alternative has this person got at the moment? Not funded according to the NICE criteria. They are referred, then they would not have their operation in the NHS. But if they can access that GLP-1 agonist, then that would be great. Sadly, they can't in the NHS at the moment because it's only restricted to diabetes for the same reason that there are so many patients out there. But it is absolutely game changer. I think that we have got again some medications. When we first started together, if you remember, that we used to have this Rimonabant and Sibutramine, which did have benefits, but eventually they were withdrawn, and we were left with only diet and exercise until we could offer them surgery. But now we have got something else, and that's great.
Good. That would be a good point at which to pause, because in a moment, or next week, we'll talk a little bit more about the long-term evidence for bariatric surgery, because you've alluded to the fact that we need to wait perhaps 5, 10, 15 years to find out the long-term effects of GLP-1 agonists, and there will be a lot of work. There's already quite a bit of published evidence long-term, but not perhaps as much as we'd like. So let's continue that in the next episode. So thank you very much, Mr. Sufi, for talking to me today. Look forward to talking to you again next week. Yeah, thank you.